Hi, welcome to the third lecture in the pediatric trauma part of our orthopedic review, and in this lecture we're going to continue talking about upper extremity injuries. A good source that you can use is this book written by myself. First topic in this lecture is medial epicondyle fracture. There is one anatomical fact that is important in this regard, which is the medial epicondyle is the last growth plate to fuse in the elbow and the distal humerus, and it happens between the age of 16 to 19 years old in boys and about 1 to 2 years old in female. So the last growth plate to fuse is the medial epicondyle. Remember, the medial collateral is attached to the medial epicondyle, so repeated stresses on the medial collateral can cause stress fractures in children before that growth plate is fused. The medial epicondyle can be an acute fracture, and sometimes this acute fracture is associated with dislocation of the elbow. And you can see here, this is one of my patients. He has medial epicondyle fracture widely displaced, and you can see the amount of hematoma here, indicating the disruption that happens on the medial side of the elbow. And as we said here, the medial collateral ligament is attached to this part. Sometimes it happens with dislocation of the elbow. What is the treatment of medial epicondyle fractures? Most of the cases of medial epicondyle fractures in pediatric patients can be treated non-operatively. The one absolute indication that you have to fix it is if fracture is associated with fracture dislocation, and then with the reduction, the fragment became entrapped in the joint, as we're going to see an example for that. If it happens in athlete with a stress on the elbow, like baseball pitchers, it can be treated with open reduction internal fixation to give them better stability of their elbows. And if it is widely displaced, and most surgeons will use more than 10 millimeter as an indication for open reduction internal fixation. So medial epicondyle fracture, most of the cases treated non-operatively. The one absolute indication is if you have the fragment entrapped in the joint, indicating that there was a dislocation and then spontaneous reduction, or it can be reduction by someone and then the fragment became entrapped in the joint. If it happens in athletes with the stresses of the elbow on the medial side, like baseball pitchers, it can be treated with open reduction internal fixation. And if it's widely displaced, more than 10 millimeter and associated with valgus instability, it can also be treated with open reduction internal. So you can see here, this is one of my patients. You can see widely displaced here medial epicondyle. So this is definitely more than 10 millimeter displacement. And if it's not only the displacement, you can see here that there is a widening of the medial side, indicating that there is valgus instability. So this is an indication to fix this fracture. So you can see widely, here is the piece here in the lateral, it's here in the AP, it's widely displaced, it's more than 10 millimeter, and it's obviously associated with a degree of valgus instability. You can see here the joint is wider here on the medial side than the lateral side, indicating that when you push it into valgus, there is obvious instability. So this patient was fixed using internal fixation. You can see here in the intraoperative, remember the medial epicondyle is posterior, so the internal fixation will be usually going from posterior to anterior, and you can see here the screw. In most cases you want to avoid here being into the olecranon fossa to avoid any blocking of the extension. And this is the picture only a few weeks showing the full fusion and healing of this patient. So this is an indication for surgical fixation of a medial epicondyle fracture. The one absolute indication that you need to fix the medial epicondyle is, as we said, if the pieces is entrapped in the joint. So this is one of my patients. He had dislocated elbow, and the reduction was obtained, and the patient presented to my office. Obviously, this reduction shows something wrong here. There is incongruency between the olecranon and the trochleum. And if you look closely, there is the piece of the bone here. This is the contralateral side. It shows This is the normal joint. Here's the olecranon and the trochlea here aligned together. So you can obviously see here that there is something wrong. They are not aligned. There is subluxation of the joint, and the piece here is in the joint. So this patient was treated with internal fixation, as you can see, and once we took the piece out of the joint aligned perfectly. So it became closer here to this picture, and you can see the difference between the pre-op and the post-op. So if they give you a scenario, for example, 12-year-old boy had dislocated elbow, reduction done, as you can see here, continued to have pain, and then they show you this x-ray. The treatment is open reduction internal fixation of the medial epicondyle. So this is the absolute indication that you need to do a surgical fixation for the medial epicondyle. The next topic is nursemaid elbow, sometimes referred to as pulled elbow. It usually happens in children around the age of 2 to 3 years old with very characteristic history. There will always be a history of the child going in one direction and someone pulling his arm into the other direction, followed by pain. The child is not able to move his forearm, and the child keeps the forearm pronated and beside his body. It's sometimes mistaken for an injury to the wrist, because the position that the child keeps his arm in. So the child will keep the arm beside his body pronated. He doesn't want to move the elbow or the arm in general. X-rays will be negative, and the treatment is reduction. The reduction maneuver is full supination followed by flexion. You keep the thumb over the radial head to feel the reduction when it happens. Usually after a few minutes from the reduction, the child will be able to move his forearm. Again, it's a very common condition, happens around the age of 2 to 3 years old. History will involve pulling the arm, and the child will keep the forearm beside the body in a pronated position. The reduction maneuver is full supination followed by flexion. Keep the thumb over the radial head to feel the click of the reduction. Few minutes after that, the child should start moving his elbow. Next fracture is radial neck fracture, and the radial neck fracture in children can occur through the physis, so it becomes a Salter Harris, or it can happen through the metaphysis, as you can see here. And in this case, it's also associated with another injury, which is elbow dislocation. In this case, it happened through the physis, so it's a Salter Harris type 2, part of the metaphysis, and then continue through the physis. The treatment of the radial neck fracture, if it's less than 25 degrees, you can observe, and this angle is the angle between the radial shaft from one side, or the perpendicular, or the radial shaft, and the physis. So if it's more than 25 degrees, first thing is to try closed reduction. There are multiple maneuvers to try closed reduction. One of them is direct pressure with the thumb. The other one is to use the smart for the tourniquet. If after closed reduction you still cannot reduce it to less than 25 degrees, the treatment should be in the operating room with closed reduction and pinning, or there is another technique called the Mitizo technique. I'm going to show a picture for this. The technique which I used and used commonly with most surgeons is percutaneous using of the wire to the reduction, and then application of another wire for fixation. So you can see here, this is a displaced radial neck that happens through the physis, so it's a Salter Harris type 2. A K wire was applied. The displacement here, as you can see, is definitely more than 25 degrees, so the angle between the perpendicular of the radial shaft and the physis is definitely more than 25 degrees. It's about like 65 in this case. A wire is introduced in the fracture and hinge it up to reduce the fracture, and then another wire is used to fix this fracture. Same technique was used in this case. Try to avoid having open reduction, because once you open these fractures, you can go into many complications like stiffness and non-union and avascular necrosis. So again, radial neck fracture can occur through the physis or through metaphysis. It can be associated with other injury, as you can see here, elbow dislocation. Treatment, if it's less than 25 degree, which is the angle between the physis and the radius, or the perpendicular to the radius, you can observe. If it's more than 25 degree, the first maneuver is closed reduction. If you fail to bring it to less than 25 degree but closed reduction, the treatment is closed reduction and percutaneous pinning, or a Monteggia technique. The commonly used technique is the closed reduction using the K-wire as a hinge, introduced into the fracture and then hinge it up, and then another wire to fix the fracture. Try to avoid open reduction. As I said, it can be associated with stiffness, avascular necrosis, and non-union. So this is a picture for the Monteggia technique. As I said, I don't use this technique. However, it has been described in the literature. First, you introduce a flexible nail or a K-wire from the distal radius. And then after you capture the radial head, you push a little bit the K-wire. So you can see here it was pushed to get into this amount of inclination, correct the inclination, and then you turn the handle holding the K-wire, so the tip of the K-wire or the flexible nail go from here to here, and this will reduce the radial head. So this is the Monteggia technique for the treatment of the radial neck fracture. This is another example of radial neck fracture. You can see here the radial neck, and the angle between the radial neck and the perpendicular on the femur is more than 25 degree. So to treat this fracture, we push this K-wire through the fracture and we hinge the K-wire up to reduce the fracture. And now the more and more the angle between the physis and the radius is getting better. And you can see here how it was in the beginning. It was like 70 degree, and at the end here it's only about 5 degrees, the angle between the perpendicular of the radius and the physis itself. And then it was affixed with a K-wire, you can see here in the AP and the lateral. After that, we go to the Monteggia fracture dislocation. This is a very important topic, not only in the exam, in your clinical work. It will come, and I want you to focus on this so that you never miss a Monteggia fracture. You can see here, this is an X-ray. This X-rays show that there is a fracture in the ulna. Everyone can see that. But if you look closely here, other than this line in the ulna, the head radius is not pointing towards the capitellum. The head of the radius is actually anterior to the capitellum. So what is Monteggia? Monteggia is fracture of the ulna with dislocation of the radial head, and the classification depends on the direction of the radial head. In children, POID 1, which is type 1, the anterior dislocation of the head radius is the most common type of Monteggia. So Monteggia is fracture ulna with dislocation of the radial head. In children, the most common is type 1, which is apex volar angulation of the ulna with anterior dislocation of the radial head. So this is a POID 1 radial head. In children, the vast majority of Monteggia fracture dislocation are POID type 1, which is anterior dislocation of the radial head. You can see here, after the ulna was reduced and pinned, the radial head is pointing toward the capitellum. So let's again see here the difference between this picture. The radial head is anterior to the capitellum. If you draw a line here, it's directly pointing towards the capitellum, as you can see here. I'd like to give you this example so to make it very clear. So this is a proximal ulna or olecranon fracture, and the radial head. You may think, oh, the radial head here looks normal. No, it does not. If you draw a line here, it's anterior to the capitellum. You can see here in the lateral, it looks, in the AP it looks fine. In the lateral view here, you can see the fracture here with apex volar or apex anterior angulation with the radial anterior to the capitellum. This is POID type 1, the most common one in pediatric. This is the contralateral side. So I'm bringing this X-ray so that you can know the difference between the normal anatomy and the Monteggia. See, this is the normal side. The radius is pointing towards the capitellum. It's direct line here. So this is the normal side of that same patient. If you can see here, I put them side to side so you can compare. Here, obvious, this is ulnar fracture and this is pointing anterior. Compare this to this. This radial head here, this radius here is pointing towards the capitellum, straight line. This is the normal anatomy. You can see here that's not reduced. This is anterior to the capitellum. So here it's anterior, here it is normal. This is the normal anatomy, this is the normal side, this is the affected side. The difference in the AP is not obvious, but in the lateral view with POID 1, you can obviously see the difference here, radius pointing anterior, radius pointing towards the capitellum. This is the broken side, this is the contralateral elbow. So reduction was done, closed reduction. Not every case of Monteggia needs surgery. Most of them can be treated closed. Closed reduction of the ulnar fracture done, elbow was flexed, now the radius is pointing towards the capitellum again. You can see here the radial head is starting to ossify. So here it is pointing towards the capitellum, so with the reduction of the ulnar, the radial head was reduced. You can see here that's comparison between pre and post reduction. Here it is pointing anterior to the capitellum. Here it is pointing towards the capitellum. Have a look here and put this pictures in your brain so you never miss a case of Monteggia. Get yourself trained that whenever you see any x-ray of the elbow in a child, make sure to chase the radius and make sure it's pointing towards the capitellum. If you have any doubt, get the other elbow x-ray. Here, this is the same patient after healing. You can see he maintained the reduction. Radius is pointing towards the capitellum, ulnar fracture had healed. So what is the treatment of Monteggia fracture? As we said, most of the cases of Monteggia fracture dislocation, they can be treated by closed method with closed reduction of the ulnar fracture and flexing the elbow. That should reduce POID type 1. So as I said, POID type 1 is the most common in children in which the radial head is dislocated anteriorly. So the treatment for this is closed reduction for the ulnar fracture and flexing the elbow to between 90 to 100, and in the same time supination. Why supination? Because we know that the biceps pulls the radius anteriorly, so you want to relax the biceps by flexing and supinating. So once you flex the elbow and supinate, the biceps now become relaxed, so it does not pull on the radius anteriorly. Treatment of Monteggia is closed reduction of the ulnar fracture and immobilization of the elbow in about 90 to 100 degree flexion with the forearm supinated. If the ulnar fracture is unstable and the radial head cannot be kept in place, pinning of the ulnar fracture can be done to keep the head reduced. As you can see here in this example, this is an ulnar fracture, so the fracture was pinned using a percutaneous K-wire, and this kept the radial head in position. Again, you will keep the forearm, the elbow in 90 to 100 degree flexion and the forearm supinated. So treatment is closed reduction. If the fracture is unstable and the radial head is not kept in place, it can be treated with open reduction internal fixation with plate or percutaneous K-wire or flexible nail. For missed Monteggia fracture, the treatment you have to do ulnar osteotomy. It's for flexion and lengthening, and you can fix that with a plate, as you can see here, or you can do gradual, as you can see here, gradual lengthening and flexion. So for missed Monteggia fracture, the treatment you have to address the ulnar fracture. So if they give you a scenario of a missed Monteggia fracture, what is the treatment? The treatment is actually osteotomy of the ulna and lengthening, and that should in most cases reduce your radial head to its position. Now let's talk about both bone forearm fracture, one of the most common fracture that any orthopedic surgeon and pediatric orthopedic will deal with. The treatment, as we know, most of them can be treated with closed reduction and cast application, especially kids 80 years old and less. In the AP, you should be able to assess rotation. How do you do that? In the AP, you should be able to see the radial styloid on one side, and on the other side bicipital biceps tuberosity. That will give you an indication that this is an adequate rotation. In the lateral, you should be able to see the ulnar styloid and the coronoid 180 degree from each other. This is how you assess the rotation. What are the acceptable alignment? Up to the age of 8 years, you can accept 15 degree angulation and malrotation of about 45 degrees. And then 9 years old and old, you go a little bit less, so you go from 15 angulation to 10 degrees angulation, and from 45 degree to rotation to 30 degree rotation. Remember, the bionid position, which it means overlapping, is accepted so long that you're keeping the rotation and the angulation within the guidelines that we said above. So 8 years and below, 15 degree angulation and 45 degree rotation. Older than 8-year-old, like 9s and older, the 15 degree becomes 10 degree and the 45 degree rotation becomes 30 degree. You have to be able to assess the radial, the rotation in the AP through the radial styloid biceps tuberosity, in the lateral through the ulnar styloid and coronoid. For both bone forearm fracture, the treatment is long arm cast after the closed reduction. It gives better control of the deforming forces than the short arm cast. However, if there is a fracture of the distal 1/3 or the distal 1/4 of the shaft, it can be treated with the short arm cast. There is something called a cast index. The cast index is the ratio of the anteroposterior internal diameter of the cast, which is measured in the lateral view, divided by the mediolateral diameter, internal diameter of the cast, which is measured in the AP view at the level of the fracture site. And this value should be less than 8, meaning that the anteroposterior diameter of the cast, which is again measured in the lateral view, is narrow compared with the mediolateral diameter of the cast, because that indicates a good molding. If the values are more than 0.8, it is associated with increased risk of redisplacement. Remember, these values are mainly for the distal forearm fractures and fractures of the forearm from the middle of the shaft to the distal part of the shaft. In proximal forearm fracture, this index was found not to be as accurate. But for distal fracture, as this fracture that you can see here, the cast index is a good indication for the risk of redisplacement. Again, you want to have lower anteroposterior internal diameter compared to the mediolateral internal diameter. If there is failure of close reduction, or if the patient is very close to skeletal maturity, the treatment is by internal fixation. Internal fixation can be plate and screws, as you can see in this example, or flexible nail, as you can see in this example. Both have the same rates of union, radial bone reduction, and forearm rotation. However, flexible nail, as you can expect, done closed in most cases or through a small incision, have the shorter surgical time and less blood loss. As we said, if you have a patient that very close to skeletal maturity, it may be better to proceed with internal fixation with displaced fracture rather than trying close reduction and casting, because there is a much less remodeling potential, and it may result in loss of rotation if there is no near anatomical reduction. This concludes this lecture, and the next pediatric fracture lecture we will complete the distal radius fracture and the hand fracture in kids. Thank you for watching this lecture, and I hope this lecture and other lecture will be useful for you in both exam and in real life practice.